Today we'll be discussing some different modalities of birth control options relevant to women's health, specifically highlighting the combined hormonal birth control pill as it is still the most common form of birth control. We'll look a little bit at the differences between monophasic and multiphasic pill packs and conventional versus extended cycle pill dosing. Our objectives today are to introduce some of the brand and generic names of common products, to assess clinical pearls when it comes to combined hormonal birth control, and implement patient counseling methods on missed dose instructions if it's applicable to the medications. So when looking at our birth control options, there is a whole menu for our combined hormonal birth control pills, so the typical birth control pill that we think about when we think about contraception. That's what we'll be highlighting most today. Other combined hormonal, so estrogen and progesterone formulations are a patch, as well as a ring that's inserted into the cervix. Progesterone-only options include the mini pill, different IUDs. There's also an implant and a shot called Depo-Provera. Non-hormonal options include the copper IUD or Paragard, and emergency contraceptives include the copper IUD as well as Ella or Plan B or Next Choice. So jumping back to our combined hormonal birth control pill, what's the difference between all the different dosing options? So our conventional combined hormonal pills contain 21 to 24 active pills and then 4 to 7 inactive pills at the end of the pack. Sometimes these inactive pills contain a little iron to try and help supplement some of the blood that's lost during the period. But on these pill packs, you're going to have a typical cycle with a 4 to 7 day period depending on the amount of inactive pills. With continuous dosing or extended cycle, essentially you're skipping some of those periods, and you take 84 active pills in a row daily and then have a period about every 90 days with the 7 inactive pills. So typically this is good for patients who have endometriosis or really heavy periods. And then if we look at monophasic versus multiphasic combined hormonal contraceptives, monophasic, each active pill contains the same amount of estrogen and progestin, whereas multiphasic medications, the amount of hormones in active pills will vary. They try and mimic the natural cycles a little bit more closely and might be useful in certain instances. So please don't memorize this slide, but this definitely gives you some ideas of the different formulations that are out there for combined hormonal contraceptives. So for monophasic, we have options like Junel. For monophasic extended cycle, we have Loloestrin and Yaz, and multiphasic options usually have the prefix tri somewhere in their name because each of the 3 active weeks have slightly different concentrations of the 2 hormones. So we get orthotricycline, Trisprintec, medications like this. So there's some important contraindications to estrogen-containing birth control. So these are contraindications to combined hormonal birth control, which is meaning the estrogen component, because our other option for hormonal-based birth control would be progesterone-based. So contraindications to estrogen based on cardiovascular risk include patients who are greater than 35 years old, who are smoking more than 15 cigarettes a day. Other contraindications include patients who are breastfeeding or less than 21 days postpartum. There is a clotting risk that comes with taking estrogen, so patients with history or risk of current DVT or PE or specific mutations that make them more likely to clot are not going to be candidates for estrogen therapy. Migraines with aura at any age is a contraindication, as well as uncontrolled hypertension. And then there's a whole host of cardiac diseases that would preclude patients from getting estrogen, as well as history of stroke. So let's talk pros and cons. You have to remember to take the pill at the same time every day. There are some adverse effects, so there's a potential for breakthrough bleeding, sore breast, and nausea, although this does usually get better after a few months. But a potential decrease in libido is usually a more long-term side effect. Pros is that they're 99% effective with perfect use. We're using real-world data. They're more like 92% effective, which indicates that out of every 100 women taking this birth control for a year, 8 of them would get pregnant. We have options for having regular periods, so monthly periods with regular cycles, or skipping periods with our extended cycles. The return to fertility is pretty quick and usually takes a few days to weeks after patients stop the medication. And some beneficial side effects we may see is that it can cause lighter periods and reduce acne. So one important counseling point for patients is missed dose instructions. If patients are missing too many doses and it's becoming an issue for them, you can always counsel them on their other options that they don't have to remember to take as frequently, like an IUD or a patch or a depot, making sure they understand their options. But just for a single missed dose, so if they haven't taken their pill for 24 hours, they should take their tablet as soon as they remember, and then continue taking the rest as prescribed, so they may have to take 2 tablets on one day. If they miss 2 doses, so go without taking their dose for 48 hours, they should take the tablet as soon as they remember, and then continue taking the rest as prescribed, and discard any remaining missed tablets. If they were missed in the last week of the hormonal tablets, then you omit the hormone-free interval by finishing the tablets that contain the hormones and then immediately start a new pack. So you skip that placebo week if they've missed 2 tablets in their last week. For all scenarios where 2 or more consecutive tablets are missed, you always want to consider counseling on the use of emergency contraceptives and using backup contraception for 7 days. Other counseling points, aside from missed dosing, that might come up are patients wondering if they need a break from hormones for their body, but it is safe to take the pill continuously for multiple years. There are patients who experience a higher risk of blood clots with estrogen-containing therapy, and if patients are at higher risk for this, always considering if estrogen is truly the right contraception method for them. And in healthy adults who are not at higher risk of breast cancer, it does not increase risk of cancer. And if patients want to change what time they take their pill during the day, they can wait until they start a new pack and just make sure there's not more than 24 hours between pills. If they are having nausea early on with their pills, one intervention that we can suggest is to try and take it in the evening so they can sleep through some of that nausea, or trying a different dose or formulation if it really isn't working for them. And always tell their doctor or pharmacist before they start any new medication, because we want to avoid any interactions that may reduce the efficacy of their contraceptives.